Okay. So we're looking at our respiratory disorders. All right. Some of the key things you want to think about is what's taking place. When we think about our tracheal disorders, right? So this is an acute phase. Acute phase means that this happened, it's less than 3 months, all right? And things like that, right? So some of the key things you want to think about is what's going on with this person, right? Key things to think about with this would be in relations to it's a tracheal bronchitis, right? Inflammation is taking place in the trachea. It's smooth membrane, all right? It's smooth muscle, the lung. Key things to think about is what does the patient present with. A lot of times in nursing, we need to look at what will your patient look like, right? You want to be able to walk in and be like, all right, what the nurse tells me in report actually match the patient. I hope. All right. So what do you expect? Patient will have stridor, right? Patient might have respiratory distress and wheezing. Patient is going to have dyspnea, difficulty breathing, right? They might have sputum, right? This is what we're looking for. How do we manage it? Meaning that what is our plan for this patient? The key things is that here what? We might start antibiotics, right? Because if the mucus looking brown and nasty, is infection, all right? Normal mucus when you have a cold, it's green, light, a little thick. But when it look brown, nasty, something's going on, right? They might have chest pain from coughing. Give them a little Tylenol, Motrin, and stuff like that, right? We want to think about fluid. If the secretions is thick, the person needs some fluid because that means they might be dehydrated. A lot of times, people don't think about the fluid balance with that. A cool vape, right? And stuff like that. Not vape in the smoke, vape in the air, all right? So you want to think about those things to kind of moisten the air, right? If they can't cough, you might have to suction them, right? Pulmonary hygiene, we call it. You have the suction. You want to do chest PT. You want to help them with do that. Rest. Get them in the bed, have them relax, get them out of the chair, have them relax and stuff like that, and make sure that they complete the course of medication. A lot of time, I take antibiotics by day 5. They recommend it for 7 days. Day 5, I feel good. I can run a marathon. I'm out. They stop taking it. Doesn't mean the infection is gone. It's just that it's subsided enough that you feel better. So they should complete the whole course. So when we think about atelectasis, right, we think about it, we say it's a collapsed lung, right? I tell people your lung is like a sponge, right? It could fall into itself. It could collapse. It's a smooth muscle, right? The alveoli is where gas exchange takes place at the capillaries. Everybody that's in here has a PEEP, right? Meaning that it keeps open at 5, right? Millions of mercury, right? So it's 5, PEEP of 5. Everybody that's breathing here, it's normal for everyone. This could be acute, it could be chronic. So in our patients that have lung disease and this reoccurs, it becomes chronic. The person that's going for surgery, they've been in bed for a couple of days, they're not really doing exercise, they don't even want to cough because it hurts, right? This could be the acute atelectasis, right? So this is what's taking place. The person could now have hypoxemia, right? They could have respiratory distress, they could have cough, they could have mucus. On an x-ray, the lung could look whited out because it's now collapsed, right? The presentation can be related to pain on the pleural area, when they cough and stuff like that. They could have cyanosis related to hypoxia. That's why we do capri fill. We check the nail beds and stuff in our assessment, right? You bring in health assessment back. All right. So these are some of the things you look at with these patients. Then we have a little pathophysiology reminder. With our pathophysiology, we're looking at someone who's at risk, right? So a patient with lung disease will always be at risk, whether it's asthma, COPD, soft emphysema, and things like that. Right. So these patients, they don't have the thing. They cannot maintain the volume. Sometimes they have infections, secretions that could cause this to now collapse. They've been sick for a couple of days and they're on bed rest. All right. these patients can face this challenge. So you really want to look and see what's taking place with the gas exchange. The smoker, a lot of times they're like, oh my God, I'm always having a cough. I'm always having it. Because your lungs is being challenged, this is what's taking place. A person with GI reflux and they keep aspirating recurrently, the lungs is inflamed, so now they're prone to have collapsed lungs, right? So these are the things to think about. What do we need to think about? Who is our patients that we are at risk? How can we prevent it? So I tell people incentive spirometry, right? You got to get the balls up, right? So I tell people the key thing to think about is starting this before you go to surgery. A lot of people say, why? The key elements with this would be for you to focus on trying to get the lungs in the exercising mode where it is breathing. So you can try to get this up, and then when you come out of surgery and things like that. Now, I know some people are like, oh, I don't want to be an addict, right? So you don't have to give them heavy medications like narcotics, benzos, this, that to treat their pain. But you could give them things like Tylenol, Motrin, Ketorolac, which is liquid, ibuprofen, IV, and that could help them reduce the pain. So now they could actually try to breathe. If I'm in pain, I have pain, oh my God, my back, there's that. Think I'm going to breathe? Really? I don't even want to get out. I'm like, leave me alone, right? But if you treat the pain, you'll get the patient to do this. Some of the key things I tell people is trying to get them to do this every time you make wrong. So you come in every 2 hours. Could you try to get this up and document it, right? And then you should see it. So it helps with lungs expansion and stuff like that. The frequency of it is important. Early mobilization. Get them from bed to chair early. All right, that's a good intervention on surgical floors. Out of bed. You'll be like, okay, wow, it's a lot. So normally the night shift, get them out of bed for the morning and they have breakfast, stand in their chair, right? Then secretion management. You want to suction them and stuff like that. You want to do chest PT. You want to be able to do that. And then if they have inhalers, promote it. When we look at chest PT, all right, we cup our hands like this and we tap the back, right? Now, if you're lazy, you could take the mask from the amble bag and use it. It works just as good, all right? And that will help break up or shift around secretions and stuff. Hopefully, they have a good cough. They could bring it up. The goal of this is to remove secretions, bring up secretions, immobilize it, help them cough, tell them to deep breathe and stuff like that. This will help them to be able to maintain that lung, so at least you could avoid them having atelectasis. Key things with this though is people get atelectasis after being on BiPAP or after being intubated on mechanical ventilation. So when somebody is extubated, we want them to deep breathe and cough. We want them to get out of bed. We want them to walk around and stuff like that. So this is some of the key things. When we think about TB, right? Tuberculosis. Everybody's like, oh my God, this is still around. It's been around for ages. It ain't going nowhere. So TB is actually more common than we know. It's actually very much common in isolation areas where people are like institutionalized. So there's a lot of TB in those areas. So if somebody comes to the ED and they tell you, hey, I was in jail. Hello, put the mask on. If they're coughing up secretions looking like blood, more than likely they have TB, right? Then somebody tell you, oh, I came back from a mission trip. I don't feel good. I'm coughing. And when you look, they went somewhere in a forest somewhere and stuff like that. Hello? It could be. They sleep in a hostel. Like, I don't know. Who was coughing in there? Who was this? Especially in winter. Because then nobody's really going outside. Everybody is inside. All right? So this is what it is. So now you're looking at it. TB is actual bacterial infection. It likes the lungs because it's nice, it's warm, it's there, but it could affect any organs. But it really likes the lungs. That's why we see it there. If it's condensed in the lung, more than likely it's not active. But if it's like patchy all over and stuff like that, and the person has signs and symptoms, which is cold sweating, fever, and stuff like that, coughing up secretion, blood tinge, positive TB test, then that's it. The risk of it is, again, traveling. We could get it on the train, right? We go in on the train, somebody cough, I'm like this. You know? Like on planes, everybody's laughing at me. I put the mask on. When they asked me why you have a mask, I said I snore, so I needed to cover my mouth. But really and truly, I'm scared. You know? People worried about COVID, I worry about TB. I'm like, COVID you could cure. TB I ain't gonna make it. Alright? So these are the kind of things you want to think about. A little bit about the patho of TB. All right, bacterial infection. It's could it really likes the lungs, so it will take over. It lives in the alveoli. It has multiple infiltrates and things like that. It is transported through like breathing, coughing, droplet. Actually, it's airborne isolation in the hospital. All right, because the droplets are so fine that it takes a while to settle. So they treat it as airborne. All right, it could go to the lymph nodes, right? So if somebody comes in and they have lymph node tenderness, it's bound to be cancer. It could be TB, all right? So you really want to be able to do that. So that's why when you're doing assessment, you're really palpating. I had a nurse. She came, she write a beautiful report, and I'm watching her, and I'm like, I read in my own chat. I have in my chat on the day, and I see the note, and I'm like, oh my God, this is crazy, right? And I'm like, this is wild. Why do I need to read my notes and you ain't listen to my lungs yet? I'm like, yeah, she said, I palpate his abdomen, non-tender. I'm like, I'm here for abdominal pain. I'm here because I'm hungry. Non-tender. I'm like, oh yeah, boy. I said, I reach where I go. Don't be that nurse. Okay? Don't go to jail. Another thing to think about with this, how long does it take to actually show up? So you could be exposed to somebody with TB 2 to 10 weeks before it shows symptoms. So you could be like, oh my God, where did I get this from? 10 weeks later, right? It's kind of scary because you could have gone on 100 places in 10 weeks. So these are some of the key things you want to think about. Now, I tell people what it looks like a consolidated mass, right? It looks like a white patching and stuff like that. All right. So how do we diagnose this? In the old golden days, all right, the old days, what do? We do a TB skin test in 48 hours, 72 hours, we read it, right? All right. It should be 0 mm. Now, people who have gotten BCG vaccine outside of the US, you see them with that mark. All right. Those vaccines were given as live vaccine, the Bill TB thing. It don't work. All right. But what it does, it actually makes you get a positive. So a lot of people with that, we don't even do skin tests because it's going to react. We do quantiferin, right? The quantiferin is more accurate. It comes back. It's a blood test. You don't have to come back for a reading. It hits you 1, 2, 3. We only do X-ray if the quantiferin is positive, or we only do X-ray if people have symptoms. All right. Before they used to do X-ray on everybody. It's not indicated. The sputum test is how you really get down to the diagnosis. All right. That means, okay, if quantiferin is positive, we see it on the X-ray, and now we want to actually send off a culture to confirm it's TB. All right. Because radiology is not perfect. It's a man telling you it looked like this, it looked like that. Hopefully he's not drunk somewhere, or on vacation rushing through the brush, right? Or believe it or not, AI is starting to read X-rays and CTs now. Yeah. I went to a conference and I was like, what? I said, oh, I have no faith in this place anymore. I said, I hope somebody's double checking this. Because we in real trouble now. All right, so good. Did you guys learn how to do PPD in fundamentals? What? Huh? I hope so. You didn't know how to do a PPD? Oh, we did. We did. All right. So in fundamentals, you know it's supposed to be a 10-degree angle. It's supposed to be a PPD needle. It's like 0.5 cc, right? And you put it right here, and it's bevel up in, and it's under the skin. It's intradermal, right? That's how you do it, and stuff like that. You all did FAM. You know our first line drugs for TB is these. I'm not going to test you on the drugs and things like that, but it's good to know because they might ask you on it in the lab. What's the side effect, or what do you expect for somebody who's taking these drugs? What do you worry about? Liver. What color would be the urine?
Orange.
Exactamente. Very good. So if the person peeing orange, ask them, you taking any new medication? The doctor will love you. You know? All right. Now, the bad thing about this is that it's not an overnight thing. Some people go on treatment for a whole year, sometimes 2 years, depending on how bad it is, if it's clearing or not, right? So it could take a while, somebody on antibiotics. Now, you don't have the option to sign out AMA when you have TB, all right? This is the only time the person cannot sign out AMA. They try to leave, we call the cops. You could get arrested. Because TB is something that is widely spread. If we let you out in the community, we could cause a pandemic. All right? So really and truly, this is the only time we could put you in jail. All right? Because this is that serious. And it's so hard to treat. What does nursing do? We make sure you adhere to your medication. We do the teaching. We know it's transmitted airborne, so you wear all your PPE, your stuff like that, then you actually would adhere to everything that you do. Right? Make sure they take the medication. If they can't take the medication, they're not going home. All right? Yeah. Literally. You can't go home. So pneumonia, right? Pneumonia is more common than you think. So we have a lot of different philosophies of pneumonia, right? And what it is, it's really an infection of the lungs, right? But it could be bacterial, it could be fungal, and it could be actually viral. So a lot of kids that get pneumonia with RSV, it's actually viral, right? It's secondary pneumonia. Then have people who get it because they didn't clean their CPAP, right? They just put on the CPAP mask and the same dirty CPAP mask, right? So that's something like that. But if you get it in the hospital, it's hospital acquired. If you get it in the community, it's community acquired, right? And hospital acquired pneumonia is normally somebody comes in, we do a procedure on them, we intubate them and stuff like that. You take them out or you take out a tube and then they never had any symptoms. And 2 days later, within 72 hours, they start having symptoms. You do an x-ray, you realize, oh my God, this person has pneumonia. That's hospital acquired. You came in for surgery on your ankle. Now you have pneumonia. You have fever, hospital acquired. Or you have the ICU nurse who want to sleep all night and don't do patient care. Don't clean the patient mouth every 4 hours. Don't turn on position, no suctioning. And then the patient aspirate all that junk. Hospital acquired pneumonia. All right? When they get a hospital acquired disease or disorder, we don't get paid. We don't get paid. I'm not happy. Okay? All right? No bueno. I'm coming. I'm like, who did not clean the patient? When the person, who killed my patient? They be like, who killed the patient? I be like, oh Lord. I said, murder. All right? So this is some of the things. So what do we expect, right? We have patient, fever, white count, right? So WBC is part of a CBC, which is how we trend our white count, right? So we're going to see our leukocytes are high, all right? Or we might see our, well, I would say C-reactive protein high. This means that there's some inflammatory response going on in the body. Sooner or later, we'll have to do a blood culture and it will tell us exactly what bacteria is there, right? This is like Klebsiella and these kind of things that are common to hospital setting, right? We had a child in cardiac surgery. When we come out, we have an open chest. We see some fungus growing in there. We're like, this is nasty. So we decide to culture it. When we see it, it's the same thing that grows on fruits. The family have a bowl of fruits in the cabinet. That's why we don't allow food in surgical areas. Because the same thing that was there, of course they blame the hospital. But I was like, mommy, you touching the child, you eating your fruits, did you wash your hands? Same thing on the fruit is the same thing in the child's chest. I'm like, this is crazy. He lived. But at the same time, it's a setback, But at the same time, it's crazy. So what do we do? If it's viral, antiviral. If it's fungal, antifungal. All right. If it's bacterial, we'll give some antibiotics. All right. But we try to avoid these things because this gives patients setback, right? Pneumonia gives you setbacks. So these are some of the things about it. So we want to think about community acquired stuff. Bless you. Community acquired, right? Community acquired, you came to the ED, you had fever, chills, you've been coughing. We do an x-ray, you have pneumonia. You went to summer rave, talk to everybody, you scream out your lungs, you share vape, you do everything, you get something, H flu. All right. So this is what it was, right? The bacteria was there, you came in with it, it's community acquired. All right, hospital acquired is what it is. Unfortunately, if that happens, we don't get paid. So make sure you clean your patient ICU nurses. All right, PACU nurses, make sure you give them the incentive spirometer and things like that. All right, for nurses who work in other units, make sure you suction your patient. All right, the other one that is PCP is associated with our AIDS population. Right now, we kind of, knock on wood, got AIDS and HIV under control. It's very rare. You see somebody on their death certificate dead from AIDS. Now it's like, people want AIDS before cancer. It's crazy, because the meds are so good now, you don't even know. Like I remember we went into a trauma case and I'm ready. If you see me, I put on my gloves. They're like, Cordell, back up. This is an AIDS patient. I said, but he look good. I said, he built buff and he got shot. I said, oh, damn. I said, I would never know. Thank God somebody read the chat. Granted, I have gloves on, it's a bloodborne, but they're like, oh, calm down, don't rush the brush. And I was like, wow, in my time when we were training, when you see an AIDS patient, they're frail, they don't look good, they're pale, they're this, that, and you think like they're ready to die. Now the AIDS, you're like, you can't tell. It's not on their forehead, right? So this is something. So you don't see this as much, but if you do, it's normally with our patients that are immunocompromised and stuff like that, right? And more than likely, it's because they don't have immune system why they develop these pneumonias and fungus and different things like that. So, it's things like that. Now, aspiration pneumonia. This is more common in our patients that might have a stroke, might have been quadriplegic, might have had something that paralyzed them, or might have CP or something like that where they cannot control their secretion. Duchenne syndrome, right? We bring it back pediatrics, where the muscular dystrophy, right? They're losing their control of their muscle, right? You are feeding them, right? And you're about to do care. You're like, oh, let me do my injection change. And you forget to turn off the feeding pump 30 minutes before. All right. So you turn them down and you see them kind of cough. They aspirate, right? When they do the x-ray because they spike a fever or they have increased work of breathing, you realize, oh, wow, the person aspirated. So, and this could be also with secretion. So end-of-life patients could get this as well as patients that, might have some chronic condition. They could aspirate just by feeding them. That's why in the nursing home in fundamentals, you see they have that little tray and they have a suction machine in the kitchen or in the dorm room. It's because as they get older, they might have dysphagia. So they might choke. All right. So some of the key things you want to think about with this is that what organism might be there. All right. How it looks. This is a beautiful X-ray. All right. I know you're nurses, so you're not going to read the X-ray, but these are ribs. The black thing is good. This should be the heart border, but all this should not be white. All right. Everything here should be ribs all the way down. This is your diaphragm, and the heart is on this side. So that white part is where your consolidation is. That's where the pneumonia is, right? So some people might say, "Oh my God, every time I cough, right, it hurts." Then they might say, "Oh, I have back pain because it's in the lower base." All right. But the key thing about this is if you actually carry a stethoscope and listen to the patient, all right? You know, people are like, "Oh, breath songs within normal limits." I was like, "So how you listen to the patient? I ain't see you take up that stethoscope one time." I'm like, Jesus. That time you see the diagnosis, pneumonia. I said, wow, normal limits. I said, you're going to jail. Did this patient die? Your family sues, you're going to jail. That's it. So we want to think about that, right? So some of the key things I'll tell you. Who's at risk for developing it without who's our risk patients? It could be our persons with, any lung disease. Common one is our COPDers. In med-surg, we have a lot of COPD patients. All right. Our patients that might have different things like, immune system problems. It could be, they say low neutrophils, meaning, your fighter cells, but it's really any immunocompromised, neutropenic is what we really call them. Our smokers, that's why we recommend that they get the pneumonia shot, right? Because we want to give them the strain. We give them Prevnar and the pneumococcal vaccine, right? I think it's Prevnar 23 now and pneumococcal. Yeah, 46 strains. I didn't know it had so much. All right, the patient that's immobile, the one who can't get up and walk, can't cough, is bedridden. These patients they're just sitting there, right? The person who had surgery, they could have problems, right? The person who has a weak cough, right? So after a stroke, might be weak. After sepsis, you might be weak. After being intubated for a long time, you might have a weak cough. So this person might be challenged, right? The alcohol intoxicated patients, they're not deep breathing and coughing, they're barely surviving right now, So you think about that. Poor airway clearance is another thing, right? Advanced age, our older patients, right? They cough too hard, they break a lung, right? And stuff like that. Post-op, these are our patients, they just had surgery, they don't feel so great, they're in pain. This is their risk factor, right? Why NG tubes?
Aspiration.
The aspiration. Also, the reason why you need to actually X-ray is that you measure the NG tube, it goes in loops and it comes back up. I had a nurse, she just put the NG tube. I said, but why does NG long like this? I'm like, why is it all the way here? I said, look, I look at the X-ray, the thing loop and coming back up. So when you feed the patient, it's coming right back in the mouth. I was like, and you are travel nurse. I said, Jesus. I said, where you went to school? When they say renewal, I said, just go report her license. Then I tell her, I said, do me a favor, go on YouTube. I want Sarah RN. How to do these things. I said, because I'm worried. I'm very worried. But believe it or not, right in New York City, you lose these skills. HHC hospitals do not allow nurses to put in NG tubes. So when you go to other hospitals and say, oh, put in an OG and an NG, they're like, what? Because they did it in nursing school. They work somewhere that don't allow them to, they lose the skill. And stuff like that. So I didn't realize that they don't do that. So I said, go back and see this one. Sorry, you got to measure from here to the back of the head, then you put it in. All right, tape it. You just push the whole tube. And thank God the patient can talk. You can imagine. All right. So pneumonia, what do we do? How do we diagnose pneumonia, right? We get an X-ray. We could actually listen to bread songs and hear crackles. You guys remember what crackle songs like? It's like a paper, like crushing paper, yeah. And stuff like that with the long songs, right? If the patient had a respiratory infection, it's very common if it didn't clear in time. They could have blood culture, could show it as well. They could have a bronchoscopy, meaning that they went in and they actually scooped them and stuff and look at the lungs. And it could be what they think was actually a collapsed lung versus now it's actually a pneumonia and things like that. And then the secretions, then things like that. It puts them at risk, right? In our older folks, confusion is either hypoglycemia or hypoxemia. An old person that is confused, early onset confusion, hypoxemia, glucose, all right, and stuff like that. If they have a fever, frequent urination, it's UTI, all right. So management, of course, will be antibiotics. Okay, we're doing any support therapy. If they have hypoxemia, we give them some oxygenation, right? We might have to do CPAP if they have COPD because oxygenation is not their problem. How many liters should you give a COPD patient?
2.
2 liters.
2 liters, yeah. And no more than 2, all right? Because the oxygen ain't going anywhere. All right. Then you'd worry about assessing the patient for any complications, right? So they could have respiratory failure. All right. Because if you're working the breed, you could have failure. You could have hypotension related to actually because they're not drinking and hydrating themselves and they're losing it. They could have septic shock, meaning that it's infection related. Now it's systemic. So it's things like this you want to think about. Some of the key things. COVID. Right? A lot of people forget that COVID is around. Every fall, it's like the flu now. It's still coming around. All right? It's never going away. It's not as strong. But some of the key things, right, is that you want to think about fever, chills, cough, headache, fatigue, right? Sore throat, loss of smell, taste, runny nose, nausea. Some people have diarrhea. All right? And things like that. So, what we think about an effusion, right? When we say effusion, it's a collection of fluid, right? A pulmonary effusion will be inside. A pleural effusion is in the pleural space. So, when they say pleural effusion, this is in the pleural space and it's pushing the lungs. So you see this area here is all here. That's why this is white. So when the person is listening, auscultating, and then they say, oh, I don't hear anything at the base, it's because of that, right? Now, if they say they're hearing gurgling or something, then we're looking at a leak somewhere, right? And I think you're going to be learning about chest tubes in lab, right? So when we do these effusion, it's a collection of fluids, we got to remove it, right? This could be related to pneumonia. It could be related to pulmonary disease. People that have malignant ones are patients that have cancer and it builds up. All right, we use our exterior drain for patients that are like in the end stage of cancer. There's not much to do. We would drain their malignant effusion. They're just, accumulating fluids from whatever tumor is there, and it just, secretes and create fluids. The person could have fever, chills, all right? They could have shortness of breath. They could have difficulty breathing and things like that. Decreased breath song or no breath song in that area, all right, is very common. How we would really know this is on an x-ray or if we do a CT scan because, okay, you complain of abdominal and back pain and we think it's the kidneys, but let's scan you. And then we realize, oh yeah, the back pain is not a kidney stone, it's an effusion, right? If it's small, we would leave it, all right? It will reabsorb. If it's big like this and the person is symptomatic, we got to treat it. So what do? We put a chest tube, right? And we drain it. So we have different things, right, that could accumulate. It could be protein, it could be pus, and stuff like that. It could be fatty deposits and things that accumulate. It's very different. The one that accumulates like the lipids are most commonly, we call it chylo. It's most commonly in our patient that had surgery or they had open chest. Yeah, or transplant patients sometimes get this. All right, so when you have pus, right, there. So I had a patient, he came in and complained of back pain and chest pain. I'm like, boy, he's like 16 years old. He big and buff and strong. I'm like, okay, what's wrong with this kid? Him, I have a plane to catch the DR. I said, well, let's make sure you're alive first before you go. When we did the x-ray, I don't know how he get that. Literally, there was fluid accumulation. When we popped it and did the chest tube, it was the nastiest thing I ever smelled in my life. I was like, this is crazy. I'm like, and it was staph. So staph infection. So I don't know if he got like exposed to it, but it was so odd. Yeah, I was like, thank God he didn't go to DR. You go up in that high pressure, you might have died on the plane and stuff like that. So a lot of times what happens is that accumulation of fluid and stuff could cause pressure against the lungs. So somebody who is having problems breathing or respiratory distress and you hear normal breath sounds, doesn't mean it's in the lung. It could be outside pressing against the lung. So that's why we do the x-ray and CT scan and stuff like that. All right. And then we'll drain the fluid, of course. All right. You guys need a break or we can continue? All right. Let's go. It's 10 o'clock. 2 minutes to 10. You guys are doing strong. All right. So we're thinking about respiratory failure. Right. This is life threatening. So you're in distress. You've been breathing hard for a while. You're not getting any relief. You're hungry for air. Now you're tiring out. So this is respiratory failure. Key things to think about with a patient with that is if a patient was breathing 30 and then without any support or correction and now they're breathing 10, it is not improving or getting better. It is failure. Patient is not doing well. Especially when there's hypoxemia, the SAT is not that great, and then they're looking diaphoretic or they're looking grayish, right? It's not good. This means that they're actually in distress or their body is shutting them off and stuff. In pediatrics, this is where cardiac arrest starts, respiratory failure, and then cardiac arrest. They don't get heart attacks. Kids don't get heart attacks that much unless they had some existing condition. With this is our patient will become hypoxic, right? At this point, you may see the changes in the pulse ox, right? And stuff. But this means either it's July 1st, you're a new nurse and the resident or the intern don't know what he's doing. So now the patient is this far. No patient should be in this distress. All right? We shouldn't have patients in the hospital coming in respiratory failure. All right? We shouldn't be coding patients at this level unless there's nothing else to do or the resident don't know what they're doing. All right? So key things to think about with respiratory failure. Of course, there's decreased oxygenation in the blood gas, increase of CO2. Okay? Then poor ventilation, so poor gas exchange, maybe breathing is decreased. I'm not gonna eat my words. Then we think about early signs would be compensation, right? So the person is trying to breathe to keep up, right? The increased work of breathing. The late signs, unfortunately, it's decreased. When we do the blood gas, we're gonna see a O2 level on the blood gas less than 60. All right? We in trouble. The CO2 is greater than 50. We in trouble, right? And the pH might be less than 7.3, right? 5. So we in real trouble. This is the patient that needs to be intubated, maybe put on ECMO or something like that because we in real trouble. All right? So when we think about ventilation failure, this is a blood flow problem. We're not getting enough blood flow to the area. This could be related to maybe a stenosis, which is narrowing of a vessel. It could be related to different diseases, whether it's a cardiac disease or something like that. Or it could be things like cystic fibrosis, which means that it has so much secretions that we can't get oxygenation or ventilation for the expansion and gas exchange, right? Capillaries are clogged. Capillaries are hard. It's a problem. All right, so we have, of course, the alveoli maybe clogged or achieved, but we also have a CO2 level, all right, that is going to be greater than 50, right? So you're very worried about the person being hypercarbonic, right? Got it? Yes? Or maybe so?
Just back,
Another background noise.
background.
Yeah, the fun job. Right or wrong all day. All right. So when we think about oxygenation failure, all right, oxygenation failure has to do with our person that's getting the oxygen, but it don't work. All right. So this is our COPD. We giving them oxygen. It ain't going nowhere because gas exchange is their problem. Right. So if we have somebody that has a COPD, they're hyperinflated. They can't really do gas exchange. The alveoli are not filtrating fast enough. They have oxygenation failure. But COPDers naturally live at high CO2 level. So if you see a CO2 50 something and homegirl is with her oxygen and she dancing and she walking with the cane and she moving, let her be. All right? But when it's really where it's extreme hypoxemia, confusion, things like that, symptomatic, then you want to treat it. All right? And these are the kind of things. Any questions about that? All right. So what happens with respiratory failure? I tell people things to look at when they think about respiratory failure is our CO2. It's our big problem. All right? You hold on CO2. If it's not corrected, you ain't gonna make it. All right? Because here what? Oxygen stops at the lungs. It's low there. What else is gonna start to die? The cells. When the cells start to die, it's gonna start at organ level. Then it's gonna move down to the cellular level. Then we're gonna have the patient dying. So if somebody comes in and they were in respiratory distress, they're intubated and stuff like that, and now you see AKI, and we're not fixing the O2 problem, the oxygenation problem, the kidneys just took a hit because the hypoxemia, now the kidneys are dying, right? Then you think about, oh, the person is having arrhythmias. The heart is now dying. Okay? Neurogenic stuff, the patient is seizing now. Maybe part of the brain actually took a hit. All right? So that's why we tell people, when you're monitoring patients and stuff like that, this is what you want to check earlier. All right? Any questions about that? All right. So these are the patients need to be intubated and ventilated. Sedation is important. I don't want to sedate them. You cannot control their thing if they fight in the vent. It's not going to work if they fight in the vent. Knock them out. All right? ICU nurses, knock them out. Okay? I don't want to see patients restrained and they're on sedation and they're fighting. They want to pull it. The only time they should be moving and pulling out tube is when you're weaning them to take them off. All right? You intubated, sedated. All right? And you're lucky I don't paralyze you too. You can't move. All right? So, when we think about ARDS, right? ARDS is the acute respiratory distress syndrome, right? This is very common when there's lung injury. A lot of times this is also associated with patients with COVID. It's associated with patients that have sepsis. And this is like an inflammatory response. So you come in, you have this disease, you're not doing so well. And in 2 to 3 days, all of a sudden you're requiring more oxygenation, right? You need to breathe more. Now, the person that was sleeping at a 30-degree angle need to be at 90 or 2 pillows on their back and stuff like that. Their X-ray is worsening. This is what's happening. So what we need to do is increase the PEEP, right? To increase the pressure. Now, while we increase the pressure, it actually could put pressure on the aorta, meaning it could actually compress the blood pressure and tank it. So we don't want to do that. As well as it could cause the lung to pop, right? Yeah, too much pressure. So we definitely want to monitor the P. So what it looks like when a patient does have ARDS is look at the alveoli, the blood vessel, and the capillaries, how it's in a normal side will look fine. And with ARDS, it's inflammation, it's buildup. So gas exchange is harder, right? So sometimes we have to use lighter gases like heliox. All right, we have to use nitric oxide, which is lighter gases than oxygen, to promote oxygenation so it can pass through all this like inflammation, secretions, and all this to help and promote oxygenation. So with ARDS and the pathophysiology section, it will tell you about the inflammatory response, how the person responds, the damage to the capillaries and things that are taking place, and then about the gas exchange, the inflammatory response, the swelling and stuff that takes place, even the edema and buildup, right? On the cellular level. Now, hypoxemia is a big thing. Also, sometimes we put down 100% oxygen because we're trying to get it. So a lot of times during our time with COVID and we intubate patients, their saturation was actually in the 80s for hours. And we're like, oh my God, this patient trying to die. So we put them on 100% oxygenation. But what we should have done is increase the PEEP to open up the alveoli, then just give oxygenation because then that would help. Now, hypoxemia refractory is really, where the person has that persistent hypoxemia for a while, so it has to be fixed. So it takes a while. So this is why it will take a while to fix it. Then we're looking at what can we do at this level, right? This person will start to have distress or whatever, so we have to tube them. We have to intubate them. They went from nasal cannula, the high flow nasal cannula, to BiPAP, which is non-invasive ventilator. This is a ventilator without a tube. So if somebody say, I don't want to be intubated, you could put them on a BiPAP. Then the next step will be the tube, right? Which is the mechanical ventilator. If that doesn't work, we could do oscillator, which is just shooting air in, or we could do ECMO, which is a pull the blood out heart-lung machine. All right? These are for the sickest of the sickest. All right? So think about how a patient will look, right? So you see this is a beautiful x-ray, no? And then look at this now. Do you think this person could exchange any air? Do you think this person could have gas exchange? No. It's terrible, right? So this person need to be prone, okay? Prone means sleep on your belly, right? You look like you're going to be swimming. Put the person like this, all right? So this is your prone like setting. Because what's going to happen, your O2 is going to be low because, again, what can you pass through this lung? How can you promote oxygenation, right? You may not be able to really get a good EKG and stuff like that, as well as you might have crackles everywhere because it's all infiltrates, all right? And the secretions. Now, symptoms does occur. The person comes in and within 48 to 72 hours, that's when they get intubated and all that stuff. The x-ray gets worse and things like that. Then we have to think about what the stress and if they're in respiratory acidosis versus alkalosis, the crackles and stuff like that. So we treated the infection that they came in with, whether it was sepsis, whether it was COVID, but now we have to do a little more to preserve and protect the lungs and hopefully promote some oxygenation so the kidneys, the heart, the liver doesn't get hit, right, with this. So in the management, of course, it's promoting oxygenation. Nurses, what we do is, in the ICU is really manage the patient. So we monitor the vital signs, we give the meds, we monitor for any complications. So like, hey, the person now have less than, how many cc's or mLs of urine should be hourly? Output, not you. Anybody?
30 an hour.
30 is the minimum. it should be 1 to 2 cc's per kg per hour. If you weigh 50 kg, we expect to have minimum of 50. The book will tell you a minimum of 30, right? But 30 is not the end all. It should be 1 to 2 cc's per kg per hour. All right? Because we want to catch the patient when they're at 60, realizing that it's dropping because they weigh 50 kg. They should have been at 100 cc's an hour, right? At the 2 level, right? Because they weigh 50 kg. If they're at now 60, that means it's trending down. So by the time it hit 50, we should tell. When it hit 30, the kid needs a shot. All right? It's time for dialysis. All right? So we want to catch it earlier. Then we promote it because again, this could be the sign of hypoxemia because the kidneys are not perfusing. Now it cannot filter and make urine, right? So that's a problem. All right. So we had to think about preventing VAPs and all these things. We had to think about positive pressure ventilation. This is the artificial airway and stuff where we intubate the patient and stuff like that. We're thinking about low tidal volume. So tidal volume is how much we give every minute. All right, which you're going to learn next week, how much we give every minute. And then we have the PEEP. We need it to be a PEEP of between 5 and 10. 5 is most normal. We go up every 2 and stuff like that. During COVID or severe ARDS, we have done PEEPs of 20 and stuff like that, but we know it's high risk for the lungs getting barrow, chest, and trauma. So this is some of it. The patient should be prone, so on their stomach, they're sleeping on their stomach. We're going to put them 12 hours on their stomach, 12 hours on their back, or 18 hours on their stomach, and 6 hours on their back, right? And try to promote oxygenation. The reason why is that when you lie flat, your gut comes up, pushing on the lung. When you lay, your gut is down, the lungs is all having the back, right? So it actually allows your lungs to expand, right? So that's the mechanism about it. So this would be a prone patient. Okay? So you think about fluid management. You also want to think about whatever drugs you need to get. And sometimes at this stage is where we're talking about vasopressin. All right, to keep the blood pressure up. We're thinking about bolusing fluids to keep hydration. We're thinking about, antibiotics if there's an infection and things like that. When they think about ECMO and things like that, this would be, what they will consult because they're worried about we can't maintain them without, the heart and lung taking a hit. When we think about chest trauma, all right, so you decide you want to be a bad boy and you run in the streets. All right, you have a rivalry gang walk up and choke you, right? So that would be, the person got stabbed, right? Or you work in construction and you forget to put on the belt or the belt fail and you come off the scaffolding, right? Fall down, right? Chest first, right? Broken rib, right? Or somebody, decides you give them a bad drive and you stop and you cursing them out and they pull out the baseball bat and whack you. Chest trauma, right? This is some of the things you want to do. With these things, you think about respiratory distress. Of course, it's going to be painful because it's maybe rib fracture and stuff like that. When you think about flail chest, it could be a detached rib. All right, that's actually moving by itself. So when you breathe, this side goes up, that side comes down. It doesn't go synchronous together and things like that. You could think about airway obstructions, whether it's tamponade or it's deviation. And you would want to manage this by managing the pain because nobody's going to let them examine them if there's pain. As well as you also think about a chest tube in case there is buildup of fluid, blood, pus, anything like that. And then maybe you had to do, thoracic opening. Well, we don't do that as nurses. The physician does, we assist. All right. So somebody comes in and they thought they were Jet Li. And they have the sword and they have a sword coming in. Who's going to remove this?
Doctor.
The surgeon. I'm be like, oh. So we had a kid maybe about 3 years ago. I was working overnight in the ED. and somebody stabbed him. And he had the knife in his chest, and one of his friends pulled it out. He died because it was occluding one of the vessels. Yeah. As soon as we open him, we crack the chest right there in the, open him up and stuff. We just see the blood shooting. I said, oh shit, it's done. Done. I said, this is over. I took off my gloves and I walk out. They were like, you gone already? I said, what are we gonna do here? I said, I'm a nurse. I said, I'm here to give the drugs and help and give the blood. I said, but if I'm shooting the blood through here and it's shooting out of your chest there and you can't even find the bleed. My God. I was like, done. I was like, this is over. So don't pull it out. All right? Keep it there because whatever it's occluded, when we open, they're going to close slowly and then remove it. All right? I was done. I was like, I'm done with this business here. I said, right? I was like, let me take my glove off. Let me tap out. I said, because I don't want to be here when they give in the news. That is what, when the rails and the scream starts, I can't. I'm out. I'm like, that's not my body. So, case study. Let's see. So we have this patient, right? Yep. Okay. So, what do you guys think? All right. Nice. So it's a pneumothorax, right? Why is it a pneumothorax? Because the deviated, right? But tension pneumothorax is the deviation. A regular pneumothorax is just that it's pushing the air and it's compressing the lung. The deviation is when it's a tension pneumothorax. It's creating tension. So if they put pneumothorax on the exam, which is evil, and then tension pneumothorax, please, if it's a deviating tension pneumothorax. All right? Tension.
So the
Regular pneumothorax you could have, and it just air is there, right? And it's pushing against one lung. But when now it's pushing over, right, and misaligning the trachea, the heart, and all that, it's tension. Yeah. So anything that's pushing over to the other side and stuff like that. So when you think about it, this is air, or it could be blood, all right, because it could be a hemothorax. Right? Because if somebody gets stabbed or get cut or something like that, they're bleeding into the area. It could be like that. So it could be trauma related. You know, somebody stabs somebody or they get cut and they breathe in at the same time or air is leaking. This could be, you know, a tension pneumothorax, right? This is normally, you know, a quick fix. We do the aspiration. All right. With the needle, you hear the air. The person starts to breathe better. They feel great. And things like that. All right. That's done by the provider. You will assist. You will be monitoring the patient as well. All right. So this would be pneumothorax. If it's closed, it's spontaneous. We don't know where it's coming from. Very common in our Marfan syndrome group. The open would be like the stab wound, a fracture, full chest that creating this. And the tension would be when it really deviating and pushing the lungs, the trachea, the heart, the other lungs out of line, right? From the midsection. All right. So this would be a pneumothorax, right? So you see ribs here and you see some tissues. Here you see ribs, but it is too light. There's no lung. All right. You got it? Or you want me to go over it again? All right. So you see here, right? This little haze and all that stuff. This is lung tissue. Over here, you don't see it on the X-ray. Right? There's no lung tissue over here. So it's not really showing what you should have, right? So when you look at this as well as when you have this, it could be stab wound, it could be spontaneous, right? For a Marfan's person, it could be blood, right? What we gotta do, our goal is to reinflate that lung and stuff and remove these things. So whether we remove it with the needle and stuff like that, where the air comes out, or then we put a chest tube later where it drains and things like that into that. For the ones that are air, it's just gonna remove the air. All right, a little pleural fluid might come out, but it's gonna really remove the air. All right, pretty decent. Now, this is just the marking in case the doctor asks you to hold the hand for the patient. All right. And they'll count. It's normally the second intercostal space. All right. And then if they're going on this side, it's normally in the mid clavicular fifth intercostal space. All right. So this is it. If you have a patient that is presenting with shortness of breath, right, and palpitation, what are you concerned about?
Heart rate.
So PE. So the person comes into the ED, shortness of breath, palpitation. Everything else looks good except the saturation. All right? You learning, it's okay.
Oh, you see me disappointed myself.
Don't beat yourself up. You're here to learn. PE. Now, the difference would be if somebody comes in and I have shortness of breath, I've been sick for a couple of days, I have fever, right? What's changing with this is this person with PE could be that they had surgery, they had a DVT, and now they have sudden onset of shortness of breath, palpitations, back pain, and stuff like that. PE. All right? Or they say, I feel like something's sitting on my chest. All right? Heaviness. PE. All right? All right? So that's some of the key things you want to think about when it comes to that. And this is dangerous in multiple ways because it could be a DVT, or if somebody fracture a large bone, it could be what we call a fatty emboli. All right? Which actually is high risk. It will kill the patient. All right? So sudden onset respiratory distress. I would say tachycardia, chest pain, and stuff like that. Maybe hypoxemia, so the SAT is low, and things like that. And more than likely, the PE is occluding a vessel. That's why the hypoxemia, the hungry for air and stuff. First thing you'll do with this is what? Put the oxygen on them. I'm hungry for air. Put on oxygen. All right, they need it. They're hungry. Because you're not going to fix this right away. The only thing you can do is give the oxygen to help while we try to figure out what's going on. All right, so this PE now will go and occlude the vessel and stuff like that. And this. So another thing, when somebody is diagnosed with a PE, bed rest. I don't care if they want to use the bathroom. Bed rest until we get that. Just going from here to there will finish them. So I had 3 cases where I wanted to choke the nurse. All right, I literally nearly go to jail. I'm like sitting down and I hear code 99. I said, what? 16th floor. I said, what the hell is going on up here? I gone upstairs. The patient is written for bed rest. She wants to use the commode. What happened? She can't poop in the bed pan? You have PE. Why you want to get up on it? She's dead on the commode. Because that little move occluded. That's it. I can't help you. Another one, she came in hyper, oxygenated the family. Oh, she got to eat. I was like, she looked like she didn't miss a meal in her life. She won't die. Please don't feed her. I go, When I come back from break, there. I said, why? No feeding. You can't breathe, you can't eat. There. All right, then another one. Perfect surgery.
Wow.
Lobanox, you have a DVT. I said bed rest. No, you decide you want to go walk, sit down in the chair. This, that. You try to get up to go back to the bed, fall out on the floor. 300 pounds. Ain't nobody picking you up. I was like, I said, I'm sorry. I said, this is wrong. You know you have risk factors. We told you you got PE. You're doing it, you're doing that. We do the teaching. It went through one ear, come through the next. I'm like, Jesus Christ. How can we do all these things? You're still there. I'm like, this is bad. You know? Terrible. So key things to think about is make sure we follow the rules. All right? And then if the patient, I am getting a patient refused bed rest order, reinforced teaching. Patient decided to get up on their own. They drop in the bathroom.
That's it.
Give happy. Give breaths. You know they ain't coming back. You know. You already know. This is crazy. So what happens with PE is a lot of times when there's a DVT or if it's fatty emboli or something like that, it leaves where it is and it reaches into the lungs, right? It reaches into the lungs. It is at that point where we realize, okay, you know, now it's occluding whatever vessel and stuff. Oxygenation is a problem. Then we have the saturation, no oxygen, the distress, the hunger for air. And if we don't fix that right away, it's a problem. So we have wonderful drugs like TPA and TNK and all these different things that will be clot busters, which we can open up. But if the person is already coding and stuff and we're doing compression, we give that, you could bleed out. So it's like high risk. We had to get you back, stop that, and then give it. Then we could maybe save you, maybe. The high is very unlikely to come out.
Wow.
If you don't follow the rules. So the danger of this is what puts us at risk. Everyday things put us at risk. Patients that have been immobilized for a while, right? Patients who might have had some fracture or something that's on bed rest could be developing. Patients that are obese, had surgery, advanced age. If you have a clotting disorder, could be the same thing. Smokers, pregnancy could cause it and stuff like that. So keep hydrated. Tell your doctor, discuss heart failure, trauma, also birth control puts you at risk. You discuss it if it's worth it or not. You know, better you throw away the husband. You know, then you know, put him in the corner and say, behave yourself. Behave yourself. All right. Let's count on the ring. This is an appointment. Otherwise, you take birth control, you may, you know, leave him and then you pick another wife. I say, it's a risk. But that's what they don't tell you, you know, and that's what I tell people, educate your patients. Oh, they never told me I could get a blood clot. I'm like, it says it plain as day on the thing. Risk. It's therapy. All right. So a lot of times we sign papers. We get educated and we don't even know what it is, the risk, and then we try to sue. You don't get no money. Because you sign the papers. All right. A lot of times the sudden onset is going to be where I have respiratory distress. Right? The person comes in, they can have chest tightness, chest heaviness, chest pain, right? Coughing and things like that. This is where they get anxious. It really is like sad to see somebody hungry for air. It freaks you out. All right. Then of course you'll have crackles and stuff because the occluding and fluid is now building up and things like that. And of course the SpO2 is thing. First thing, elevate the head of the bed. Promote oxygenation. Put on a non-rebreather. Nasal cannula is only 4 liters max. All right, this person needs 50 to 20 liters. 100% going in. So a non-rebreather, make sure you inflate the bag before you put it on. All right, take off one of the pieces because you don't want to also have them, you know, choking on it and things like that. Now, we do have heparin that we use, which heparin subcutaneously is actually preventative. Heparin drip is what you need when somebody has PE, IV. All right. When that is recovered and resolved, then we can think about Eliquis, Coumadin, Xarelto, and things like that. Later, we'll be checking PTT. All right, which it will be our Coumadin and stuff. APTT is what we will do for heparin. All right. And then we'll also manage for bleeding. We want to monitor if there's bleeding risk and stuff. And that's what it is. So heparin does not treat the PE. It stops it from becoming bigger. What treats the PE is your clot busters, right? Or when we go and we take it out, all right, with the suction. So sometimes when they go in and they do PE treatment, they use alteplase, which is TPA to neck the place and stuff like that. We use the same thing for strokes because just as this blood clot went to the heart and to the lung, cause a PE, it could go to the heart and cause a STEMI, or it could go to the brain and cause a stroke, right? So this is some of it. Then they could actually treat with these anticoagulation, and then they could put the ICD filter in, which is a filter to protect from more clots coming up. All right. So how do we prevent it? Educate the patient, right? Try to stop smoking. Reduce the smoking. Cut the smoking, right? Because it put them at risk. If somebody's traveling, so you know people like to travel non-stop, 18 hours. Get up and walk. If you know how you have venous insufficiency or something like that, talk to your doctor. Pop an aspirin. Thin out the blood a little bit. Because sometimes, I remember I had this woman, I'm telling you, nice lady, God bless her. She come off the plane and drop right there in immigration. And if you see me, I'm like, shit. I'm like, oh my God, the woman died right there. I was just like, the lady was just talking on the plane. PE, dialysis patient, had dialysis 2 days before, and then get up and fly. Remember with dialysis, we remove fluid. When we remove fluid, the blood is viscous. She's sitting down 5 hours nonstop. I was like, oh my God. I'm like, Jesus. When I see EMS, I was like, all right. I'm like, you coming to get the corpse? I said, the problem is, I hope the family not out there when we go get our bags and coming out, because imagine they're waiting for the family member. Oh my God. I'm like so anxious. I'm like, get my bag. God, I tell her, took a Uber. I said, take me home. I said, I want to get out of here because that would be something crazy. So it's becoming back and it's too much. So you think about these things, right? Now, stockings, compression stockings. You know, these nurses now, they wear the nice stockings. That's what it does, compression stockings. So like people who have all these circulation problems, they have the full stockings for them and compression stockings, and they can promote, venous return, right? So things like that. As well as the high risk person could be on anticoagulation. A lot of the older people, they put them on heparin, right? They put them on aspirin, baby aspirin, 81 milligrams a day. So you see all these people, they're giving meds, 81 milligrams. Why are you giving it? The risk, right? So sometimes, they don't have cardiac problems. Why are they getting this? Preventative. Because the person can have cholesterol, which could create that plaque, and that could break off and cause things. Or it could cause platelets to build up on those plaques and then break off and become a PE. So that's why they're utilizing that. So blood thinners. Quick question. Who is less likely to be non-compliant with blood thinners?
Older people? Older people?
No. Which gender?
Oh, males.
No. Females. Believe it or not, the studies actually show that females are less likely to be compliant with it because everybody want to shave their leg, right? They want to wear the short dress. But when you have blood thinners and you bump into here, you get bruised. It takes a while to heal. And half of them ain't wearing no stockings anymore. So they can't hide it, right? They can't wear their shorts. They'll have to wear pants or long skirts, right? It's not going to fit for them. So a lot of times they're like, I'll take it here and there and stuff like that, more non-compliant. Now with blood pressure medication, it is the males because,
So my system.
the stress, nonsense. And then you get a stroke and you die. Crazy. I be like, listen, you had your time to be macho. Relax now and enjoy the fun, right? So key things to think about, of course, we tell people electrical razors because again, if you nick, you're going to bleed longer than the average person, right? Then the bruising, the dental work, we want you to discuss with the dentist because when they start drilling and you start bleeding, it's going to be perfusing. So you may have to hold it 24 hours before. Of course, you're not going to take anything that's NSAIDs, right? So you're not going to take aspirin, you're not going to take naproxen, all these good things, because now that's going to cause more bleeding. Same family. All right? No contact sports, right? Of course, we're thinking about skin checks and stuff like that. We're definitely thinking about, notifying your provider if you have persistent bleeding or injuries and stuff like that. Any like unknown bruises that are appearing. You want to think about it because maybe you need to do blood work. Also with stool, they might want to do stool softeners so that they do not have like tears, rips, constipations and stuff because it could cause some problem. All right. Any questions? Concerns?